Okay. Are we ready to start, Carol?
Yeah, ready.
Okay. So welcome to this short paper session of the ASGBI, which will be moderated by myself. I'm an upper GI surgeon in Gloucester, from Katie Cross, who's a lower GI surgeon in North Devon. I'm sure you're all aware, it's a 3-minute presentation with 2 minutes for questions for the short papers. And when we get onto the talking posters, it's just a 3-minute presentation again with only one question that we can have a bit of a group discussion at the end. So if everyone's happy, I'll let Katie introduce the first presenter.
Okay, our first presenter is Keith Hussey. He's talking to us about has the screening programme for AAAs in Scotland introduced inequality of care. So Keith, over to you.
Thank you very much. I think I would like to start by thanking everyone who's been involved. I think the organisation that's gone into this has been a hell of an achievement to bring it to this stage. To set the background to what we're talking about here is I'm a consultant vascular surgeon and I work in Glasgow. And the co-authors on this paper are people who've come to me to complete a quality improvement sort of project as part of an undergraduate curriculum supervised by one of my senior registrars. My senior registrar is currently on Skye and so wasn't able to be involved because she's somewhere where there is no broadband. If we could go to the next slide, please. Screening was introduced for abdominal aortic aneurysm in Scotland in 2012, a little bit behind England. The reason for introducing a screening programme was to reduce aneurysm-related death. We know that in Scotland, 2% of people over 65 years old may die of ruptured abdominal aortic aneurysm. In terms of the patient groups that we have the people who come to us through the screening service, and all of us as consultant vascular surgeons will have a group which we have defined for this as surveillance detected aneurysm patients. So effectively what we mean by that is patients who come to us through other services and who have aneurysms detected by other investigators. They are a group of patients who we keep under a surveillance program, but we run that ourselves rather than running through a screening service. When screening was introduced in Scotland, there were a number of metrics against which the service was going to be examined to try and ensure that patients were treated appropriately. The two that we chose to look at when we did this quality improvement work were the NICE recommendation that patients with aneurysm should be seen within 2 weeks of being identified as having an aneurysm that was greater than 5.5 centimetres, and key performance indicator 3.2 in the Scottish aneurysm surveillance criteria, which said the time from diagnosis to treatment should be 40 days. If we can go to the next slide, please. When we looked through our database, we identified 109 patients who had had aneurysms identified and who were investigated and then taken to treatment. There were 109 consecutive cases, of which 17 were screen detected and 92 were surveillance detected. When we looked at the median time from diagnosis to clinic review, we could see that with our screen detected patients, we performed well. We performed less well with our surveillance detected patients. But when we looked at time from diagnosis to intervention, KPI 3.2, we could see that really, although we did reasonably well with our screen detected patients, there was a very significant difference between the screen and surveillance detected group, as summarized at the bottom. If we can head to the next slide, thank you. In summary, what we were able to demonstrate is there is clear inequity between the screen and surveillance detected patients with aneurysm. Undoubtedly, this is because the screen detected group start a series of processes which, as a regional unit, we will get criticised on if we don't meet. Subsequent to this, we put in place a series of strategies to try and manage the inequality, because clearly treating these patients differently is entirely inappropriate. That's all, thank you.
Thank you.
Thank you very much, Keith. I haven't got any questions up on the screen yet, so maybe I'll start. Do you think the delayed surgery impacted on your patient's outcome?
I don't think it did, and it's one of the very interesting things about KPI 3.2 that's been introduced, or at least as part of the Scottish Aneurysm Screening Service. In terms of patient outcome, which is how we measured our performance with our surveillance detected aneurysm through NVR, I'm not sure that we have the time to intervention is really relevant. But it's something that's been introduced as a metric to record performance against, and it's something that we have to work towards. So as a outcome measure, no, I don't think it's relevant.
Okay. And so what part of the care pathway do you think isn't being replicated between the screened patients and the surveillance patients to account for their delay?
So I think that with the screen detected referrals that come to us, because we know that effectively the clock is ticking from the time of diagnosis, there is pressure driven through our service. We've got someone who collates the screen detected patients and they get pushed into clinic appointments reasonably quickly. Now, we achieved that with our surveillance detected group. But one of the things that with the surveillance group is time from diagnosis to intervention is clearly much longer. So when the screening program introduced the KPI that we sought to work towards, we introduced a kind of an accelerated investigative strategy. So patients would attend for a one-stop clinic where they would get a CT angiogram to look at aneurysm morphology, and they'd get cardiorespiratory assessment. Now, to begin with, we were only able to get enough time slots to offer that on one particular day. One of the things that we've sought to do to try and reduce the inequality is expand upon that. And this work that was done was an important tool in trying to at least increase our access, I guess would be the best way to describe it.
Brilliant. Thank you very much.
Thank you.
Okay, we can move on to the next presentation, if that's okay. This is entitled Two-Week Rule, a little too late in detecting upper GI malignancy, going to be presented by Joshua Fasui from Lancashire Teaching Hospitals. Joshua.
Thank you very much. Good evening, everybody. So I'll be presenting today's topic entitled Two-Week Rule, a little too late in detecting upper GI malignancy. Next slide, please. So the basis of our study was founded upon national statistical data, which shows that upper GI cancers collectively account for some of the poorest and survival rates at 1 in 5 years out of all cancers. The majority of these patients actually present with advanced disease, with evidence showing that more than 3/4 of patients die within 1 year of diagnosis. So many of the methods to sort of permit early diagnosis and improve outcomes have been put in place. However, with what makes early recognition of upper GI cancer relatively challenging is the fact that many of the earlier symptoms are relatively non-specific, with patients dismissing these symptoms, or in fact primary care physicians attempting to treat these symptoms, leading to further delays in diagnosis. With this being in mind, there have been clear efforts to attempt to facilitate early diagnosis, but unfortunately these are a little too late in making any significant improvements to the historical poor outcomes that are associated with upper GI cancer currently. So our aim was to assess the outcomes of upper GI cancer referrals under the 2-week rule to the upper GI cancer clinic at Royal Preston Hospital as part of Lancashire Teaching Hospital, which is a tertiary cancer care centre. Next slide, please. The results show that essentially, we had 466 patients included within the study, which were referred under the 2-week rule to the Upper GI Cancer Clinic between April and October 2018. And the pickup rate for cancer was 9.2%, of which 79.1% were primary upper GI cancers. As you can see from the pie chart, the minority of patients were diagnosed at stage 1 disease, where the majority of patients were diagnosed with advanced stage disease. Looking at the management outcomes, we can see that only a handful of patients were managed via curative surgery, whereas the lion's share of portion of patients were managed via palliative care pathway. Next slide, please. So our study essentially replicates the data and the findings in the literature that support that upper GI cancer patients are presented at an advanced stage where the curative options are limited. And the current methodology of the 2-week urgent wait referral process is unfortunately a little too late in identifying upper GI cancer at an early stage. There have been changes in delivering the structure of care with the rapid diagnostic centres, cancer alliances, and changes to the cancer waiting times recently. However, the effects of this are yet to be established. And on the basis of promising evidence, we suggest then the review of the current processes with regards to 2-week wait referrals for upper GI cancer, improvements in patient education about the signs and symptoms of upper GI cancer, and also research into new methods of developing diagnostic biomarkers as a means of improving diagnosis, making it earlier, and improving overall outcomes. So that concludes my talk on 2-week rule, a little too late in detecting upper GI malignancy, and I'd like to invite you for questions. Many thanks.
Thank you very much. Actually, I didn't bring up the Q&A. There's nothing there at the moment. I've got a few things. Interesting that 9 other cancers were detected. What sort of cancers, just out of interest, were detected that weren't esophagogastric?
So in total, in terms of the primary upper GI cancers that we detected, that we were looking at, were pancreatic, esophageal, stomach, liver, and gallbladder. So the latter ones had the lower frequency, but sort of esophageal, stomach, and pancreatic cancer had the highest frequency. The non-GI cancers were colorectal, actually. We had a few, I think 2 cases of colorectal cancers that were referred to the upper GI cancer clinic that were diagnosed and subsequently managed appropriately.
On the 2-week wait referral form that you received, when you looked at the symptoms that were put down, was there any way they discriminated? Did you find any difference between what symptoms were put down for positive and negative results?
I did look at, so on sort of looking at the findings, we did look at the positive predictive value and what symptoms people were suggesting. And I did make sort of information with regards to if that reached the significant PPV as well. Although that wasn't particularly the focus of my study, I do have the data for that. The focus of the study really was to look at the outcomes of the referrals and to see if these match the findings in the literature and see how we can improve the outcomes. But I did have that data yet.
Okay. What suggestions would you say should be made to the 2-week wait referral form based on your study over this 6-month period and 400 patients? Have you any thoughts on how you would help GPs?
Yeah, I think the first thing is, I think I've mentioned about patient education, but I think there is room for education for clinicians as well, because as I mentioned, the delays in diagnosis can come as a result of clinicians trying to treat these symptoms that they might regard as benign, but actually they're pre-cancerous symptoms or early stages of cancer. So it's just about informing GPs about the signs and symptoms of cancer. And there have been loads of public and pilot studies that look at patient education and public awareness, and that has shown improvements in getting GPs to refer more patients to the 2-week wait referral clinics, and also getting patients to the GPs as well, and that's shown some positive moves in that direction. So I think there's definitely room for that. In terms of the, sorry.
I was going to say, most 2-week wait referrals go direct to endoscopy, don't they? And the problem we've got is we're overwhelmed with dyspepsia and reflux symptoms. And you mentioned in your last slide about novel diagnostic biomarkers that could be used before. Can you expand on that and where you think we may be going in the future?
Yeah, sure. I think the driving force behind it is more so the fact that a lot of the tests at the moment are quite invasive or expensive. So really the driving force is that we need to develop novel biomarkers which are readily available, which can be found in gastric juice, for example, pancreatic juice, saliva, the blood. So there are some that are in the works. So we've looked at things like exosomes, which can be found readily in the blood, and different samples like pancreatic juice and things like that. Then we've also looked at downstream markers of genetics. So KRAS has been implicated in pancreatic cancer, for example, and some of the inhibitors of that pathway have been looked at as phase 1 trials as well. So there's definitely scope for of these, and I've even mentioned the SPIT trial, which is something that's been done at UCL to look at esophageal cancer as well. And obviously saliva being a readily available sample, we've looked into that as well, and there've been some promising but small changes.
Thank you. I mean, you're quite right. We do need to be able to discriminate better. So thank you very much for your talk, and we'll move on to the next person.
Thanks very much.
Okay, so our next presenter is Lydia Newton, and she's presenting from North Bristol Trust regarding patient-reported surgical site infections after elective colorectal surgery. Are they patient-reported or medically diagnosed?
Thank you very much. Good evening, my name is Lydia. I'm a core surgical trainee working in the Severn Deanery. And yeah, I'm going to talk today about patient-reported outcomes following elective colorectal surgery in relation to surgical site infection in particular, and whether these outcomes are really patient-reported or whether they're medically diagnosed. Next slide, please. In the UK, we have a number of surveillance audits aimed at capturing surgical site infections. Getting it right first time, and Public Health England tend to focus on inpatient and SSIs and readmission rates, however. And standard measure for SSI is infection by 30 days. As enhanced recovery protocols are reducing our lengths of stay, SSI is going to be increasingly presenting in the community. The Health Protection Agency has a validated questionnaire, which is shown here, which is aimed to identify patient-reported SSIs, and it's mandatory to be used in some specialties. So we use this questionnaire to measure 30-day patient-reported SSI rates in all elective colorectal resection patients over 8 years, from 2011 to 2019. And we use postal questionnaires along with telephone follow-up. Of note, 2 of these criteria, as you can see, do require patients to be prescribed antibiotics in addition to having symptoms of a surgical site infection. The aim of our study was to identify when, where, and how patients are presenting with SSI. Next slide, please. So there was an excellent response rate to the questionnaire at 81%, and of those that completed the questionnaire, the SSI rate was approximately 16%. 3/4 of the SSIs presented following hospital discharge, and so otherwise would have been missed with typical SSI audits. 60% of the SSI patients presented with their wound issue to a community professional, and although some of these patients were readmitted or had a post-discharge ward attendance, we do know that about 50% of these patients were only seen in the community. As well as SSI symptoms like redness or discharge, 92% of patients were prescribed antibiotics. So one could argue that for these patients, they were in fact clinician validated by the nature of being given antibiotics. So actually only 8% of these SSIs were purely patient reported. In contrast to this, we do know that there are some discrepancies with PROMs. Some patients said they were not readmitted to hospital, but we know that they were. Some patients had an SSI but failed to complete the questionnaire. Next slide. So to conclude, our study found that most SSIs present following hospital discharge, and highlights that current SSI audits are going to be grossly underestimating SSI rates. Although the questionnaire for patients is a self-reporting system, the vast majority of these SSIs are actually clinically confirmed. And so these patients were prescribed antibiotics. But we do know that PROMS data is sometimes inaccurate, and we recognise this. So going forward, audits which focus on inpatient SSI and readmitted rates are going to be underestimating SSIs. PROMs are good, but they're labour intensive. Our high response rate was only achieved because of telephone follow-up. So ultimately, going forward, we need better linkage between primary and secondary data systems to help to capture our post-operative complications, as current methods of data collection are variable and our results are inaccurate. Thank you.
Okay, thank you very much. That was a really good piece of work. I understand probably not all yours, given the number of years it's gone over. But do you think potentially, are we discharging patients too early?
So I don't think it's necessarily that we're discharging patients too early. It seems that the length of stay rate is going down over time with enhanced recovery. And so these patients are just being captured following discharge, as our mean length of stay was about 5 days. So, and these SSIs aren't presenting till beyond 5 days. So we're just not managing to see these patients in hospital with their SSI.
So do you think it's something we should be warning GPs about more to expect?
Yeah, I think more support in the community for GPs in terms of them being aware that this is something that we're unable to detect because patients are getting discharged sooner than they were in the past, or whether or not we actually need to have something in place in secondary care in order to follow up these patients ourselves in order to detect the SSIs to reduce the burden on the GPs.
Great. One last question. Do you think we over-prescribe antibiotics for SSIs?
Yeah, I mean, 92% of these patients getting antibiotics, admittedly, is a high rate of antibiotic prescribing. Only about 50% of the patients get a swab of their wound, and so we don't really have firm objective evidence these patients have an SSI. And maybe if we were able to follow up these patients ourselves in secondary care, we'd have possibly a lower antibiotic prescribing rate.
Of the 50% who had a swab, do you know how many had a positive bacterial culture?
I don't know, no, sorry.
My impression is probably similar to yours, that if a GP sees a patient with a red wound, they give them antibiotics.
Yeah.
Brilliant. Thank you.
They're under, I think, as you can see, there's a lot of patients are being discharged early. A lot of patients are have operative wounds, and a lot of these patients are having to seek community support because there isn't the support provided from secondary care. So the burden's high for them.
Great. Thank you.
Thank you.
Next presentation is carrying on with the same theme. Reducing surgical site infection rates in colorectal surgery, a quality improvement approach. Rachel Faulkner from NHS Highland.
Good evening, and thank you for this opportunity to present on behalf of the NHS Highland Colorectal SSI group. Reported rates of surgical site infections following colorectal surgery vary, but may be as high as 30%. And this is significant given that colorectal resections are one of the most common elective procedures in the UK. We know SSIs confer additional morbidity and mortality to these operations, as well as having a substantial economic burden. However, adopting groups of evidence-based interventions or bundles has been shown to be effective in reducing SSI rates. Next slide. Our unit is a large district general hospital serving a population of around 300,000 patients in the Scottish Highlands and Islands. Prospective surveillance of colorectal SSIs began in 2011, and the initial 6-month pilot found the SSI rate to be much higher than expected, around 16%. And really this provided impetus for creating a multidisciplinary working group to translate emerging evidence on SSI bundles into a practical strategy for reducing rates. For example, ongoing data collection is undertaken by the infection control team, which captures readmissions and reinterventions within 30 days. And I think crucially, they carry out a root cause analysis on all recorded cases of SSIs. And this allows common themes as well as specific issues to be identified and used as a basis for ongoing education and improvement. Next slide. So just over 1,000 patients underwent an elective colorectal procedure between 2011 and 2018. Age, gender, BMI, ASA grade, and wound class were similar, although the proportion of patients undergoing laparoscopic surgery did increase over time. The graph shows that the SSI rate decreased from 16% in 2011 to 5% in 2018, with the most notable reduction in superficial SSIs from 13% to just 2.5% in the last year. And the table shows the dynamic changes to the components of the bundle over the same time period. Next slide. Our results corroborate those from other single-center studies which show that implementation of a comprehensive bundle can successfully reduce SSI rates, particularly superficial wound infections. Although there remains debate about the optimal bundle components, a combination of interventions is needed to address the complex etiology of wound infections in colorectal patients. However, it's clear that success will be limited without a strategy for effective implementation and evaluation. And our experience supports a multidisciplinary approach to create shared ownership, which I think can also help move away from the view that SSIs are purely a surgical problem. Thank you.
Thank you very much. Very impressive results of a quality improvement project, and seeing those improvements in your results as you made those sequential changes and looked at how they worked. Have you done any cost analysis? Because I quickly caught on the second slide, you know, there's quite a complex thing, new tray, regowning, putting new gloves on. Is there a cost analysis for a cost benefit for how much you reduce infection and what it's cost to get there?
So the work is ongoing, and that's certainly going to be focus of some future work, but at the moment I don't have any accurate figures for a comparison between cost saving and the cost of implementing the bundle. Yeah,
okay. And in terms of patient quality of life, have you done any work on that as the difference it's made as you've implemented these three bundles that you've gone through? Have you done any quality of life work on that, or what difference it's made in?
Not specifically in NHS Highland, but I think we know from other studies certainly reducing rates and particularly deep and organ space infections has a significant impact on how quickly we can rehabilitate patients and reduce the rates of readmission to hospital and reintervention. So I would imagine the impact on quality of life is significant, but it's not something we've yet specifically measured in NHS Highland.
Can I ask what the, sorry Mark, what was the Highland's view on bowel prep and antibiotics?
So I didn't have time to mention, but in line with the international guidelines, we have now introduced mechanical bowel prep with oral antibiotics for our colectomy patients. So that's been done in the last year, and going forward, we should have results from that change in the next couple of years.
So this is a change. So up until this point, do you routinely not use bowel prep then?
Not from these results, not with oral antibiotics, no.
I mean, that's very impressive. Thank you.
Okay, thank you very much. Thank you, very, very impressive. Just one final thing. Is there any one or two things you think are crucial in the bundle that you give, are more important than anything else, or do you think it's the whole bundle?
I think it's the whole bundle, and also the kind of team approach to implementing it, and also evaluation with compliance. Rather than one single individual bundle element that really has made the difference.
Do you have a regular audit meeting that looks at your SSIs?
Yeah, so the colorectal SSI group meets monthly to discuss the cases, and results are disseminated to the departments electronically.
Okay.
When do you redrape?
Sorry?
When do you redrape? You put in there redrape, and I've never read about that before.
So just before closure of the laparotomy or port sites.
They take everything off, or they redrape over the top?
Over the top.
That's interesting stuff.
That's why I was thinking about cost and how that. Thank you very much. If people want to ask more at the end, I thought that's a fascinating study. Thank you very much. We'll move on to the next one.
Okay, so the next one we've got is Sophia Ahmed talking to us about prevention of perioperative hypothermia in major abdominal surgery.
Hello, hi, I'm Safia Ahmed, working as a trust grade doctor and colorectal surgery. We did introduce an approach for prevention of perioperative hypothermia in major abdominal surgery. Next slide. So as we know that inadvertent perioperative hypothermia itself causes a surgical complication accounting 20% in surgical complications, which increases the perioperative and postoperative morbidity. It accounts starts from 1 hour before the induction and it lasts 24 hours till the surgery, and the physiology of thermoregulation itself is compromised by the environmental and the anesthetic factors, which causes adverse surgical outcomes. So there have been different strategies and prevention measures have been introduced to counteract the hypothermia. So such as risk assessment, warm blankets, maintaining body temperature before the surgery, and the room temperature during the surgery. Warm blankets have been introduced and avoiding medication. Next slide. We know that all of these measurements have been introduced to minimize the perioperative hypothermia, but the thing that we noticed when we were going under colorectal surgery is that the head is always exposed, and nobody gives a special attention to the head and the scalp, that it could be it's a major body surface area where the heat losses can occur from this from the head and the scalp. So we introduced a silver insulating scalp hat, where we where all the patients who were undergoing abdominal surgeries, we made sure that they wear the silver hat before going to the theaters and in the anesthetic room and into the surgery and perioperative period. They used to wear them. So we monitored the core body temperature in the preoperative phase, perioperative, and postoperative phase. So we identified 10 patients who had major abdominal surgeries in which there were elective surgeries and in colorectal and emergency laparotomy. So the mean operative time of these patients who underwent was 4 hours and 50 minutes. So the core body temperature was controlled in and maintained in a controlled temperature with normothermic, and the mean average was 36 and 36.5 degrees Celsius throughout this period. So it was interesting to see that there was no fluctuation in these patients throughout the period of perioperative throughout the perioperative period. Next slide. So as we went through the NICE guidelines, there have been multiple strategies regarding pre-warming before 30 minutes before induction, and there have been devices introduced such as active warming, IV fluids, warm blankets been introduced, beer huggers. There have been even recommendations of forced to air warming devices and heating mattress, but the exposed part of the scalp, which is mostly on the anesthetic tables where their IV fluids are there, IV lines are there, and it can be one of the contributive factors that the heat losses may occur on this on that part of the body. So with this hat, after reviewing, we came to know that it can minimizes the heat loss if we introduce this hat when the patients are wearing this hat throughout the period, and it can be on additional preventive wear and should be standardized in all major abdominal surgery. That's and we made sure that they wear, and it's quite effective in especially when the patients are undergoing for major long duration of the surgery. Thank you.
Okay, thank you. Did you measure what temperature drop you got when you didn't wear the silver hat?
Well, yes, there was a time when during, as we all, the patients usually worked more than 36 hours when they were under induction. But those, before we introduced this hat, we noticed that there is fluctuation in the temperature where the patient is to go into 35.6, 35.7, which is a various of fluctuation. And sometimes they get into quite hypothermic and they tend to towards 37 degrees Celsius. So yes, we noted a variance of the temperature throughout the period if they didn't wear the hat, because they had anesthetics, which they, and the anesthesia and the anesthetics, they encourage this thing, because they say that mostly the perioperative hypothermia is when the patient is not prepared and there is no pre-warming, and because of the core temperature from the central and peripheral, if they are uniform, and when the patient goes under induction, so and the perioperative hypothermia is minimized.
I've got a question that's come up from Lydia. Oh, hang on, it's just gone away. Mark, can you see it?
Yeah, I can. Question is, what's the cost of the hat? Because you can no. What's the question? Is what's the cost of the hat? Because anaesthetists have used towels or blankets or other things to keep the head warm. Can you elucidate on that?
Well, and frankly speaking, it's been newly introduced, and it's frankly speaking, I'm not aware how much the cost is, but I can ask that and I can update it that how much it is. It's not that expensive, because we are introducing it into our trust, and it's quite impressive.
Is it reusable or disposable?
We are disposing it. We're not reusing it.
Sorry, I got distracted in the chat there.
Yeah.
Is there any risk of overwarming? Did any of your patients get too hot?
Well, not that I'm aware of. That we monitored 10 patients, and they were not hypothermic at any stage of it. No. So, but yes, we those patients who did not wear this hat, we noticed that they were sweaty, and the scalp was quite warm. One not wearing, and sometimes it's quite cold, and so it was variant between them. Yeah.
Okay, thank you very much. I think we're moving on to the posters now.
Yeah, we're on to the posters. This is just one question at the end of each. It's still just a 3-minute presentation, and there has been a question coming up on the previous paper, which we could do at the end before everyone leaves, just for a few minutes, if that's all right. Just don't all go until we let you. That'd be very kind. You can have your supper a bit later. So the first one of the talking posters, as this called, is in vivo hernia mesh testing, a 10-year scoping review by Thomas Whitehead Clark from University College London. Welcome.
Hi, thanks. Good evening. Yes, I'm just going to briefly go over quite a large scoping review we did at the the Institute for 3D Models of Health and Disease at University College London on hernia meshes. And before these meshes are used in humans, they first obviously need to be tested in vivo in animals. But what we were noticing is that actually a lot of the methodology is very variable, and there's no real standardization. So what we did is we conducted a 10-year scoping review, looking at every study from the last 10 years in which a hernia mesh was implanted into an animal, and then assessed either for one of three things: either its biomechanical sort of attributes, or histopathological assessment of the structure in how the tissue relates to the mesh, or the cellular sort of inflammatory activity. And so we conducted a review of the Medline and MBase databases, and used strict inclusion-exclusion criteria, and ruled out all the studies until we had 126 left. So just going to go briefly over in the top right in the results section over some of the more interesting results. So if you look in the top left of the results section, you'll see a table there that looks at what models were used to test the meshes in animals. And highlighted in red in that top right-hand corner of the table, you'll see that actually the most commonly used model that we saw was actually where the mesh was implanted at the same time that the defect was made, not a chronic hernia, but it was put in at the same time that the defect was made, and that the fascia wasn't opposed. So it was used as a bridging mesh, which is obviously not a physiological way to repair hernias. And you'll see highlighted in green just further down, only 5 of the studies actually used what we'd consider a more physiological repair of a hernia, that being a partial thickness defect that has been allowed to mature, and the fascia defect has been closed afterward. This becomes even less physiological when you look just below at the graph, where at overlap between fascia and mesh, And there you'll see that actually when you're using these bridged models, there's actually quite a poor overlap between fascia and mesh, all of which were less than a centimetre. So most of these studies using a very non-physiological repair. Looking more at the hernia mesh testing, the graph on the bottom right of the results section shows the widths of the testing strips. So these strips made of either hernia mesh and tissue put together, and they were tested for their tensile strength. And essentially the widths of these strips vary greatly, anywhere between 3 and less than ½ centimetre, depending on which study you look at. And whilst there are international standards for the tensile strength testing of fabrics and plastics, there's no great guidelines actually for mesh or tissue samples. And finally, in the top right-hand corner, you'll see that actually histopathology assessment of these samples, whilst collagen is assessed quantitatively quite a lot to look at as a sort of surrogate marker for healing, its alignment and its organization is actually not really looked at that much. In a quantitative sense, it's commented on qualitatively, and there's good evidence to suggest that actually collagen alignment and how organized it is actually is a good indicator of its biomechanical properties. Looking at this histopathology assessment, there are lots of different scoring systems that samples used, and we found actually 20 different scoring systems in the literature to describe the histopathology of how meshes react, or how tissue reacts to mesh actually rather. So in summary, the methodology and comparators used in the literature are actually very variable, and there's no gold standard. Animal models offer a very poor physiological mimic to human hernia repair. The mechanical testing speeds and strip widths vary greatly, and actually looking at histopathological assessment, not only is collagen not assessed quantitatively, but furthermore, there are many different scoring systems used, at least over 20 that we found. And so further standardization is really used so that good data can be gathered between different studies with regards to in vivo hernia mesh testing.
Thank you. Thank you. Presumably you're now able to write out the standardization of how it should be tested. You have your views on that, do you?
Yeah, I think there are several different ways in which standardization could be achieved pretty simply. I mean, to come up with exact standards, we'd have to look at it more, but I mean, things like closing the fascia it should be one. Things like coming up with a strip width that's I think the fascia should be closed. We should present it as a chronic defect. With mechanical testing, as I say, the strip width should be uniform. The testing speeds as well, we found great variation in that. So you could put together a good 5 or 6 very basic standards to really standardize the field.
But presumably it's the company producing that mesh has its own goal for what it wants to present as its data on that mesh. So the companies determine themselves how they test them, is that right?
Well, yes and no. So a lot of these studies some of the studies were involving new meshes that were being brought to market, but other studies were actually done by other groups on pre-existing meshes, not necessarily being brought to market. But yeah, a lot of them will be financed by mesh companies. But yes, the variability in the field gives rise to obviously innate bias between studies that we can never rule out.
Thank you. We have to move on. That's all I'm allowed to ask.
Thank you.
Okay, so moving on to the next poster, we've got, I can't read the name, sorry, from Amanda here, talking to us about subtotal cholecystectomy, whether they should be fenestrated or not.
So I can't actually get my video up again. It just keeps going in and out. So is that going to be an issue?
No, we can see your poster if you're able to talk to us through it. Are you able to? Or...
Yeah, I can talk through it. Hopefully it comes back on the video. So I'll just start. So we did a literature review looking at fenestrating and reconstituting subtotal cholecystectomy. So the definitive management is the surgical removal of the gallbladder in the United Kingdom, with about 60,000 operations per year. The operation itself is usually very difficult, fibrosis and inflammation, to make dissection very difficult. So far, the research has looked into differences between subtotal cholecystectomy and total cholecystectomy. And there's a lot less education and research looking at the different types of subtotal cholecystectomy.
Amanda, can I just pause you for a moment?
Yeah.
Can someone mute their microphone, please? Someone hasn't muted. You can go back to Amanda's presentation about the fenestrators. I'm so sorry, Amanda.
That's okay.
Take us from there.
So basically there's two types of subtotal cholecystectomy, the fenestrating and reconstituting. So fenestrating closes, sutures the cystic duct internally, whereas reconstituting closes off the lower end of the gallbladder. There's been a lot less research on these two different subtypes. So our aim was to look at these two different subtypes and with the primary outcome of bowel leak rate. So we conducted a literature review and we looked at randomized, non-randomized and retrospective studies. And we found that the fenestrating subtype will cause a higher risk of bowel leak compared to the reconstituting subtype. So in conclusion, we feel that more studies need to be done looking at these two different subtypes, as it does like fenestrating subtotal cholecystectomies is related to bowel leak, which is related to increase in hospital admission and mortality morbidity. That's the end. So it's very noisy in the background.
Yeah.
Oh. I hope you heard me.
Yeah.
Yeah,
the person, Geetinder, who is on there, you need to mute your microphone.
Yes, loud.
Thank you.
Thank you. That's very good. I did want to ask, are there any complications that are seen associated with closing the cholecystectomy stump? For example, recurrence of the symptoms?
So I haven't actually looked into that, but the researchers out there does say there is a link between subtotal cholecystectomies and collections, supposed hepatic collections and gallstones as well. That's the data so far is very limited, so really much more needs to be done.
Brilliant. Thank you very
You
much.
mentioned a number of things that could be done for a fenestrated one to try and reduce bowel leak. Have you ever considered using glue in the cystic duct orifice? Have you come across that, or any data on using glue?
So using glue, did you say? Sorry.
Yeah.
So no, I haven't come across it, but I can definitely like read into that and see if that does make a difference. But using glue within the bile duct.
Well, not within the bile duct, in the cystic duct stump.
Oh, no, I haven't come across it yet.
Okay. Thank you for your presentation.
Thank
you. I just, if Geetinder Kaur can hear me, could they mute their microphone?
Or Carol or Vicky, have you got access? Can you mute him? That seems a little quieter.
Okay. Okay, moving on to the next poster presentation. Okay. Palliative stenting of colorectal cancers is a safe procedure in selected patients to be performed as an outpatient procedure from Aneurysm, Ashon, from the east of England, Colchester, Suffolk, and North Essex. Thank you.
Hi, hello.
Hello.
So I'm going to be talking on my poster, which is essentially outpatient stenting for palliative colorectal cancer, a safe option. As we know, bowel cancer is one of the most commonly encountered cancers in the United Kingdom, and around 8 to 13% of patients present to the hospital with large bowel obstruction, usually. Now, emergency surgery was normally the prior treatment of choice, but these days another option that's been quite popular is the use of colonic stents. And as per the guidelines, colonic stenting is the primary treatment of choice for patients who are palliated with malignant colorectal disease. So the aim of our study was to assess the outcomes in patients who essentially underwent palliative stenting for colorectal cancer. So we did a retrospective analysis over a period of 5 years, and we identified a total of 92 patients who had been stented for bowel obstruction due to a primary colorectal cancer. Out of these, 59 were done electively, and our exclusion criteria were patients who had stenting for any other cause, essentially benign disease, extracolonic obstructions, or obstruction from a different primary. On analyzing our data, we found that patients we stented had a median age of around 80 years with equal distribution among both the sexes. Out of the total of 59 patients, 30%, that is 18, had a planned stent, which was done via a cancer colorectal multidisciplinary team meeting. That is, they were done electively. And out of these patients, 77% of the patients went home on the same day itself. That is, they were essentially outpatient procedures. We also looked at the correlation between the site of the tumor and the decision to stent them. And as you can see in the table below, that the position of tumor did not preclude the decision for these patients to be done as day cases or as outpatient procedures. On reviewing our complications, we looked at the common complications such as perforation, reobstruction, abdominal pain, bleeding, migration, and procedural failure. And out of the total 59 stented, 66% had no immediate post-procedural complications. The 30-day mortality for our patients was noted at 13%. This was essentially from the patients who were stented as emergencies. There were no mortalities which were documented in the planned cohort. So on reviewing our data, we came to a conclusion that essentially stenting for colorectal cancer is quite a well-tolerated procedure, and it has quite an acceptable complication profile. So there is scope for the procedure to be done as an outpatient procedure, but essentially in patients who've been discussed extensively in cancer colorectal MDTs and then decided on a planned date. Thank you.
Thank you. From your data you've got here of this group who are just a consecutive group, can you devise criteria that would allow you to select the patients that are suitable for a day case?
So essentially, I tried to go through the patient's MDT notes to find out why they were chosen, but I couldn't really assess the reason why they were chosen. But looking at the patient data, there was no differentiation among the patients. They had similar ASA grades. They were quite Rockwood of less than 5, essentially, ASA 3 to 4. And there was no essential criteria to bring them back electively. So I can't really answer that.
Okay, Katie, have you got anything to add?
Yes, I have one question. So what level of perforation is acceptable? This is 10%, which is associated potentially with a 50% mortality rate.
Yes, so the patients who we looked at perforations were actually treated conservatively. They didn't have to go back to theater for any procedure. So we were, from what I could see, it was just a mild localized perforation without any extensive complications from that.
Okay, thank you. Move on to the
next poster. So we've got Mr. Lefray discussing theatre utilisation and whether we can get it right or not.
Yeah, hi, my name's Becca. I'm a SHO working at Walsall at the time of this project, looking at how we manage our elective general surgical cases, whether we're putting enough cases onto the theatre list in order to maximise the amount of time that we have. So essentially this has become actually more relevant now than at the time when I did the study. Now that COVID-19, we're starting to open up our theatres again, especially where I'm working, to elective procedures. It's important that we try and maximise how we're using that operative time to make sure that we can not only get the appropriate cases done, but get them done safely in enough time. The objective was to try and work out how this process of staffing theatre lists happen, and to try and optimise it and make sure that we're using all the time and not running over on a regular basis. So we looked at a month of elective operating, looking at how long cases took and whether individual half-day cases were running early or late and those that were running on time. And looking at the results, so in Walsall, where this study was done, the process by which a theatre list is populated is that the consultant will place their own cases on a list. This is then separately run through a management group who will decide whether these cases appropriately filled or not, and add or take away cases as they see fit. And that's informed by a computer program run in our hospital. So the results show that 80% of those lists were based on consultant recommendation alone. So 80% was based purely on what they thought they could fit into one list. But looking at the results of those lists, there's actually a relatively even spread as to whether those lists finished on time, early or late. 20% of lists, or just over, had influence from the management team where they were advised to remove cases or add extra cases on. And looking at how those lists ended up, the vast majority of them would ended up finishing early. And we counted early as anything more than leaving an hour left of operative time, which potentially is extra cases that could be done and potentially wasting theatre time and resource. Our computer prediction program was actually very interesting. So if you look at how it predicted our lists, it predicted that 72% of them would run under, which didn't translate into how our lists overall turned out. But if you look at how accurate it was the most accurate out of any of the different tools that we used, with 50% of the time it being able to correctly predict whether the list would finish early, late, or on time. And there is a couple of extra important points that I wanted to raise. So in 14 specific cases, or 27% of these lists, clinicians were asked to add extra cases onto the list, but they refused them. And in these 14 cases, the lists either ran late or finished on time without adding any additional cases. 2% of the list, so only one individual half-day list, both finished and started late. So using the excuse of, oh, the list started late, that's why we've run over, wasn't really a reason for why we were finding our cases were running late over into evenings. And the anaesthetic time, the median anaesthetic time, was only around 20 minutes per half-day list, which is interesting because I don't know how many of you are involved in general surgical lists, but normally several cases you'd almost expect about double that for anaesthetic time. And I think that my experience shows that this is probably more of a reflection on an inaccuracy in recording of times of patients getting to theatre and when they're transferred through. Now, obviously, that's a speculation. I don't have anything to back that up, but that's an interesting point to look at in the future. So we've made some conclusions from this, but I think going forward, this was only a month's worth of data, and actually it would be really interesting to see how this changed over COVID-19 and what happened during those times, to try and see how we're operating has changed our theatre lists. And so the plan is to do a further 3-month snapshot study during COVID, look at this and translate that into a theatre meeting which involves both consultants and the managers to sit down together and make these decisions, not only to save time but also to make sure that the theatre staff are more informed in this process, because they, we believe, have insight that would be valuable to this. Thank you very much.
Thank you very much. That's a great study. So I've got a question, and Anne Pulley-Blank has got a question. So we'll start with Anne's. She'd like to say, great study. What factors did the computer take into account? Did it include the anaesthetist, comorbidity, and predictive operative and anaesthetic difficulty due to obesity, airway, etc., or just previous operating times?
So yeah, it was actually the latter, which you wouldn't expect given how accurate it actually ended up being, but it's based on the specific consultant's previous operating time. And I think it allows for a small amount of patient individuality in terms of the difficulty of the case, but I think it's very broad. It's, you know, difficult, easy, hard, rather than, you know, redo surgery, complicated, multiple previous laparotomies or something like that. So it is much more statistics based than actual clinical data information.
And did you get a feel on which cases are predicted less well by the clinicians?
So the cases that are predicted less well are the smaller cases. So I think the big resectional cases were always predicted relatively accurately by the clinicians, especially because they see them in clinic themselves. It was the lap chole list, it was the hernia list, and it was the lumps and bumps list, where I think there's also probably unexpected change over time that isn't accounted for, with you know, cleaning theatres and things like that in between, where we don't have very good computer documented data of where that time goes, but it's suddenly, when you look back at where times are inputted, it's disappeared. And I think that's probably where we're losing some time.
Brilliant. Thank you very much.
Not at all.
Thank you. Last poster presentation of the evening, a review of abdominal perineal excision of the rectum surgery. Sarah Barlow from Lincoln.
Hi, good evening. Thank you for having me. So my audit was about APER. So patients traditionally undergo an APER for lower rectal tumours. However, sort of the newer technique that's been happening with the ELAP shows that research has an association with lower recurrence rates. So with increasing numbers of ELAPs within our department that we're performing, it was sort of time to review our performance with the guidelines. So our audit evaluated 64 patients with data collecting retrospectively between 2014 and 19. And comparisons were made between the staging process, so looking at the pre-op MRIs and the histology reports, and evaluating between the two groups with the AP group and the ELAP group, looking at surgical and patient outcomes. So to begin with, we looked at the TM staging on MRI reports, and we found that 94% of patients had an actual TM stage. 4 patients of our group just had a descriptive report and not actually sort of a number figure for the T, N, and M. When reviewing our histology reports, 15 patients were proven to be EMVR positive. And when correlating this with our pre-op MRIs, we found that 8 patients actually didn't have a comment on their EMVR status, and actually 4 patients were actually documented as negative. Moving on to looking at the two groups, so the EPEA group and the ELAP group both had 32 patients within each other. And what we found was that we're doing quite well, very well really, with our laparoscopic sort of rates. We're carrying it out in 44% of those, 44 patients, with the APL group having 19 and the ELAP 25. And we're carrying a small amount of open surgeries, 8 for the AP group and 3 for the ELAP. And these findings are suggestive and supportive that ELAP surgery is more superior to the traditional AP resections, with higher laparoscopic rates at 78% compared to 56% in the APR group. We're producing better margins at 90% compared to 65%. Moving on to look at sort of local recurrence, we're finding that again, the ELAP group produce a better local recurrence rate at 9.3% compared to the AP group, which are getting at about 21%. Finally, what we wanted to look at in the patient outcomes was complications. And what we found that the majority, or even sort of nearly 50% of complications come from perineal wounds. And they're similar across both groups, looking at 34% in the ELAP and about 28% in the 34% in the AP group and 28% in the ELAP. And we generally think this probably is down to the fact that the majority of patients are going through neoadjuvant chemoradiotherapy, and so wound healing is a problem. So in conclusion, what we found is that radiology reporting needs improving to help with treatment planning and ensure that all patients are getting the standard of care. A standardized pro forma should be now in place within the radiology department. ELAP has better outcomes with recurrence rates, improved mortality and clearer margins. And in the last year, rectal surgery in our department has moved towards more performing ELAPs. And what we're doing at the moment is actually having 2 consultants operating on these procedures. This data set included 3 operations that had 2 consultants leading on this, but it was too early to analyse any data on that. But we have started data collecting, looking at 2 consultants operating compared to 1 to look at what our surgical outcomes are. Thank you, and that's me done if there's any questions.
Thank you. Not my field, so I'll just ask a quick thing, and Katie might want to ask something. It's interesting that you've got 7 surgeons, so you're a large unit doing colorectal surgery, but only 3 are doing ELAP, and your data's better for ELAP. Yeah. Do you think that's because, as surgeons, we should even sub-specialize and do certain things more often? Is that the difference, or is there something else I'm missing?
I think in our department, because obviously in that field with looking from 2014 to 19, that's quite a lot of years, but we only had 64 patients. So the time you know, cutting that down to 7 surgeons, you're not sort of getting the numbers enough, I think, to try and get as greater margins. And so sort of getting more skilled, certainly as a subset of operations, I think was a key, just to allow for better surgical outcomes and better, you know, to try and reduce our recurrence rate. We've got fewer consultants operating on them now to try and, you know, increase their numbers and their skill with the technical, you know, the surgical technique, really.
Thanks. Katie, have you any comments?
Yeah, what's your what was your follow-up rate for the APRs versus the ELAPs?
The follow-up rate on recurrence?
Length of follow-up, yeah. No,
So,
not well, on overall. What's
so obviously a lot
mortality?
Yeah, so a lot of our ELAPs are obviously the more recent operations. So you might find that if we follow them up further down the line that we have done with the APRs, you might find that that would skew the outcome for sort of complications or recurrence rates. So most of our ELAPs have been done in the last sort of 4 years, whereas the APRs have been over sort of the 6-year process.
And you're brilliant, and it may account for your very difference in mortality.
Yeah, exactly. Yeah, so obviously some have only just had their operation sort of, you know, last year. So obviously the outcome is not, so, you know, we can still follow them up.
You can't produce a Kaplan-Meier curve for the 2 groups yet.
No.
Brilliant. Thank you very much.
Thank you.
So we've got a little bit of time. I think we can go back to Anne Pulley-Blank's question regarding SSIs. Mark, have you got that available?
I have, but I don't know whether Anne wants me still to do it. She was just asking, I think it was the paper from NHS Highland about did they use antibacterial, I think it wasn't clear, antibacterial sutures, second dose of antibiotics, were they included in the bundle? Have we still got
Hi.
Rachel there?
Yes, so I think both of those were perhaps part of the RSPAC was just trying to get all the information on the slide. But yeah, so, you know, we were certainly quite diligent about particularly second dose of antibiotics, and even installed a dedicated whiteboard for antibiotic timings in the colorectal theatre, which was something that had been fed back from the floating scrub teams as being helpful to ensure that the compliance with that part was met.
Okay, thank you. I hope that answers the question. Have any of the other attendees got questions they'd like to ask any of the presenters? I think it's been an excellent session and worked very well. Any questions from anyone else about anyone else's work? You can be as critical as you like.
We've got a few Q&As up now. Anne again would like to ask how you close your perineal wounds, and do you use tissue flaps or negative pressure dressing?
So that would be a question for myself with the perineal wound. So we're using mesh, a biological mesh. And a question sort of I had to sort of my own department was how much do we sort of involve the plastics team? And at the moment we don't, we're closing them primarily with a mesh.
Brilliant. And then just the skin over the top and no flaps.
Yeah, no flaps. So I think if we have any patients that we think need, because in our department we don't have the plastics team, so they would have to be referred to a tertiary centre.
Okay, perfect. And there was another one. I'm very grateful, Anne. Oh no, Anne's just told me to ignore the next question, so that's great. Thanks.
She has got a question though for the study about theatre utilisation. Is Rebecca still with us? Just saying, she asked, what factors did the computer take into account? Did it include the anaesthetist, comorbidity and predictive operative or anaesthetic difficulty due to obesity airway, or just previous operating time? So was it factors that would affect the anaesthetist as opposed to factors affecting the surgeon?
Yeah, I think I answered this a bit before. So it was based mainly on the individual surgeon as well as the anaesthetist, and it did have vague factors to do with the patient. So whether you predicted it to be difficult, average, or easy, not easy surgery, but uncomplicated surgery, but it wasn't specific on particular details. So I don't think it would go as far as including ASA or anything like that, which is interesting given the fact that it actually turned out to be the most accurate at predicting the running of the theatres.
Do all your patients go to a pre-assessment clinic and are assessed anaesthetically at all?
So it depends on the complexity of the operation. So if they are fit and well and it's a minor operation, for example, a straightforward hernia in a young person, then they wouldn't necessarily have to be seen in preoperative assessment. But if they are anything less than that, then they're normally seen in pre-op. I don't believe they always have an anaesthetist seeing them in Walsall's pre-op. I think it's seen by a nurse who will flag those that need to be run past the anaesthetist.
Okay, thank you.
Okay, does that bring us towards the end, Mark?
I think it does, yeah, thank you. I think so. I mean, if everyone's happy, I think people are hungry. We should be going out for a conference dinner now, I think, really.
Yeah. So the ASGBI want to the ASGBI wants us to promote to you looking online at the e-posters. There is some extraordinary work that's gone on this year, and it's so great that we can bring it to you virtually and not lose it all together and have to wait a whole year for it to be presented. So do look online and look at the posters, particularly around the other your talks that have been done by others.
And additionally, just to mention, there's 2 more of these paper sessions. There's one tomorrow night at the same time, one on Thursday night, and they're well worth doing. Tomorrow night is transplant and vascular. And there's also a talk on general surgery in the transplant patient. And then on Thursday, important webinar with the Moynihan, Neela and short paper of distinction. So they're well worth tuning into. And then again, on the ASGBA website, there's a number of webinars about topics in general surgery happening throughout the month of August. So I encourage you to look at those. Finally, just thank you all for presenting, and glad you got your presentations in, and you know, effectively you've had a virtual meeting, and wish you all the best. Thank you very much.
Bye-bye.
You can all switch off.
Thanks very much.
Thank you.
Thank you very much.